Hi, Dr. Perez here. Today we're going to talk a little bit about thoracic outlet syndrome. There's a comment of one of our patients. Their son is a left-handed pitcher, 15 years old, and has been struggling with pain on the throwing arm, has several symptoms, numbness, swelling, visited several orthopedic surgeons. Although he has tried some physical therapy and non-op treatment, he continues to have the issues. The last orthopedic surgeon recommended surgery, and that's interesting because we just had an encounter with one of our Railcats player that had the same condition and he underwent surgery, so we're just going to cut to the video and explain everything.
We really want to put a little bit more of a name and a face together. So we want you to know who are the Railcats and who is your team.
All right. Physical first. Huh? Viejo, chacho.
Thoracic outlet, medial nerve composition, I guess you would call it.
Transposition, no Tommy John?
No Tommy John, so medial nerve, ulnar nerve transposition, and carpal tunnel.
When was the TOS surgery?
July 2021.
Thoracic outlet syndrome, TOS, is the compression of neurovascular structures serving the upper extremity. That is the brachial plexus, subclavian artery, and/or the subclavian vein. The brachial plexus and subclavian artery pass through the scalene triangle, whereas the subclavian vein passes through the costoclavicular space. The patient is prepped for surgery.
So, like the video said, it's an issue of compression of a group of nerves that connect the neck with the arm. It can compress the blood vessels that run through it. Those nerves and vessels goes through certain structures because they pass in between a muscle group. If this patient is very muscular and has a big scalene muscle, when that muscle contracts or fills up with blood, it can press on the nerve and causes symptoms. Anomalies in the human body, like a cervical rib. Ribs, as you know, they are in the thorax, in the chest region, but there are some patients that can have a rib on the neck. So that extra rib compresses the structures because the structure passes under it. So it is important to know what is causing the compression so we can treat it right. Because if the compression is for a thick muscle, we're not gonna take out the rib, right? Because that's not gonna help it. Same way, if the compression is because of an extra rib, you don't take out the muscle because it's not gonna help it. So that's very important.
Surgery, which includes the placement of a shoulder roll and identification of important anatomical landmarks. The surgery begins with the supraclavicular incision.
So before we go into the details of the surgery, most of these issues are treated without surgery first. And it's a very difficult condition to diagnose because symptoms are very vague. They can have clammy skin, they can have bluish discoloration, they can have non-specific pain. Most of them can complain of pain along the trapezius, but the patients I see they complain of shoulder pain, which is very general. The way we diagnose this is with a trial and error. We try certain things. If they don't work, we try another thing until we actually see that the patient is getting better. But for the most part, the initial treatment is physical therapy to release some of the muscle tension, postural exercises. You can also do injections or nerve blocks to numb the nerve in certain areas to make sure that we know where the compression is occurring. Now, the patients that don't get better, they end up with surgery. In my field, because I see a lot of sports injury, I see this condition mostly in pitchers because of their repetitive overhead movements. But other athletes that can be affected are heavyweight lifter, CrossFitters that do a lot of overhead presses, swimmers because of the movement of the stroke, and rowers because, you know, that constant rowing movement tends to affect that area.
After the skin incision and division of the platysma, subplatysmal flaps are created, revealing the sternocleidomastoid muscle. Then the sternocleidomastoid is retracted medially. The next structure seen is the anterior scalene fat pad, which carries lymphatic vessels. The anterior scalene fat pad is reflected posterolaterally after the lymphatic vessels are ligated and divided. The structures forming the boundaries of the thoracic outlet are seen next.
All right, here's important. It's showing you the anterior scalene muscle, which is a muscle that is very big and thick. It compresses the artery and the nerve, causing those symptoms. As you can see it in this area. I don't know if you're gonna. You can see it here.
It is important to identify and protect the phrenic nerve as the anterior scalene muscle is released, mobilized, and divided. The middle scalene muscle is also released, and special precaution is taken to protect the long thoracic nerve. Next, the first rib is transected posteriorly at its neck while protecting the middle and lower trunk of the brachial plexus. Then the procedure can.
As you can see, you do a cut on the rib. It's not like you take out the whole rib, but the area that lays underneath the neurovascular structures, that's almost like a floor, you take out so there's no compression on the floor side, and also there's no compression from the muscle on the top side. So
continues with an
important part of the
infraclavicular
procedure.
incision. After the incision, the pectoralis major muscle is split, and the subclavius muscle and costoclavicular ligaments are divided from the first rib. The first rib is transected and released from its attachments. The first rib resection is then completed, releasing all the intercostal muscle attachments.
As you can see, they took out the front part and almost 2/3 of the rib all the way to the back. They don't go and resect it from the vertebrae because that's another approach and you cannot access it through there.
Attachments, alleviating the compression on the neurovascular structures. After the procedure, patients are encouraged to resume full range of motion as soon as they can tolerate it. Post-operative physical therapy is a very important aspect of recovery, and it is usually initiated between 3 to 5 weeks from the surgery.
Yeah, so depending on the amount of time that the nerve has been compressed, it can take a while for those symptoms to disappear. If the nerve has been compressed for a while, then there might be some atrophy changes to certain muscle groups, and that's why physical therapy is important to strengthen and regain the normal muscle tone so you can be functional. Symptoms from vascular compression, such as bluish hand or warm, cold skin, those tend to disappear almost instantaneously. Also, because a compression of the blood vessels can cause blood clots, we need to make sure that there's enough blood supply going in and out from that area.
Depending on the recovery and pain control.
And that's TOS in a nutshell. Now back to the video. All right, let's do a quick one. When did you last throw here? Haven't thrown?
Not a game, no.
Oh.
I played through a bullpen yesterday, just normal play test.
Okay, push up, up, thumbs down, push up. Lay down for a minute. A little bit tight here.
Always. Head draft in 2013. I think it's been the same ever since. So.
Now we're here is fine.
Well, I'm missing,
The
a rib now, so.
True. Do you had 12 or did you have 13 ribs overall?
No, I had the normal amount.
Normal amount?
Yeah. They just took out my first on this side here. And then they released the pec minor. And then
Not many surgeons that do that surgery.
it was terrible, I'll tell you.
That's why.
It was bad.
So after that surgery, did the symptoms on the arm get better?
So I had completely white hand, numbness. Basically, it felt like I was throwing like a pool ball, like no seams. I couldn't feel anything. Really, really weak in my hand. Got the TOS, came back pretty quick. The numbness went gone, got color back in my hand. It wasn't white anymore. So TOS, this, and then this.
Gotcha.
When I got the medial nerve, pretty much a waste of about 10 weeks of my time. And when I did the ulnar nerve, the numbness went away. And
so you had the TOS, but there were still some symptoms on the hand.
It didn't come back to normal.
Because usually, I mean, how long were you having the TOS symptoms?
It happened like that. I got traded to the Rays in 2020 from Cincinnati, right before the playoffs in 2020. I like slept awkwardly, like when you fall asleep with your arms asleep or whatever. And I like, went to wake up and you just shake your arms and I wake back up. It's like my hand just never woke up.
But did it get numb while throwing?
Oh yeah.
So you were just
letting it rip. Right. Basically, I had no idea where it was going, but I was having success, so I'm like, I'm not gonna say anything. 2020 didn't have anything. Make the team in 21 with Tampa. Started getting it back again. I go from throwing 95, 96 to like randomly throwing like 88. They're
right.
Like, what's going on? And it was 88, like nowhere close to the strike zone. They're like, something's up. And I was like, dude, my hand's been messed up for a while.
And finally, you spoke up.
Yeah.
Well, I'm glad I've never had a pitcher that had TOS, had surgery. That's why I'm asking all these questions.
Oh yeah, absolutely.
Because I see what could be TOS, but the diagnosis in particular, it's a hit or miss, trial and error.
We did the MRI, right, all that stuff, the scaling, all that,
right.
And then we did the test where it holds me up,
pulses,
lose my pulse, or pinches, top of my fingers, and they turn white. They don't come back to color. They just kind of stay white.
Stay white in this position.
And now it's fine.
Like immediately, or you had to wait like
a little bit. But obviously, like with throwing, right? Like
right.
I was sitting there for about maybe a minute or 2 minutes, and I could feel my hands started tingling, and I'm like, okay, it's about to happen. Like I could feel it.
Okay.
It's about to happen.
All right, cool. So now I know what to tell my little leaguers when they come.
Hopefully, no one that you know is good, because it honestly was not the best. I appreciate it. Thank you very much.